I'll start then. Yeah. Good evening, everyone, audience in person and online. Today, I'm going to talk a little bit about hypoglycemia in the inpatient setting and the quality improvement initiative taken by us in the VA. I have no conflicts of interest to disclose. And the topics that we shall discuss are islets, insulin, and glucose, pathophysiology of hypoglycemia and the counter-regulatory mechanisms, causes of hypoglycemia, glycemic control and the inpatient, incidence and risk factors in the inpatient setting, significance and impact of inpatient hypoglycemic events, and our VA experience with the multidisciplinary hypoglycemia committee. So we start off with a case of a 66-year-old Caucasian male with type 2 diabetes, hypertension, tonsillar metastatic squamous cell carcinoma, who presented to the hospital with the concern of failure to thrive and a sacral wound. He mentioned poor oral intake and appetite. He had lost about 20 pounds in the last 2 months. He mentioned recurrent falls and a sacral wound, which was chronic but had been worsening recently. Review of systems was otherwise unremarkable. His past medical history was significant for type 2 diabetes, hypertension, anemia, metastatic tonsillar squamous cell cancer. He had had a tonsillectomy and appendectomy in the past. He lived with his son, who was partially independent with his ADLs, and there had been a history of prior heavy alcohol use. There's esophageal cancer in his father, and his allergies were significant for penicillin. Now, of note, his outpatient meds listed showed atorvastatin, citalopram, lisinopril, and glipizide. However, on questioning, he said that he was not taking any medications for his diabetes control since his oral intake had been so poor at home. Okay. All right. So physical exam was significant for sarcopenia and loss of muscle mass. His BMI was 16.5 and he weighed 108 pounds. The rest was overall unremarkable. Now, labs were significant for anemia with a hemoglobin of 8.8, rendering the HbA1c unreliable. It was 7.2%, but the rest of his labs significant were his electrolytes were normal, no hyponatremia, no renal or liver dysfunction, which are important in hypoglycemia, as I will get to. Glucose was 116 on admission, and his TSH was 0.6 and cortisol 14.5. So the patient was admitted, started on tube feeds. He was unable to tolerate continuous tube feeds, so they changed him to nocturnal feeds and with an oral intake during the day. Now, during his hospital stay, there was marked variability in his glycemic control. So 5 units of glargine were started, and this was gradually increased to 15 units daily. And he was started on a low dose correction scale, also called sliding scale, and it was increased to medium dose correction scale during the hospital stay. As his oral intake improved, he was changed to the tube feeds were discontinued, and 330 ml of boluses were given after each meal. And the patient was consuming about 70 to 100% of his meals. No scheduled prandial insulin was started as his oral intake had improved during this time that his intake had improved. Now, what happened on the day prior to the event? As you can see, his sugars went up to 400 because he was eating better. And he got 10 units of aspart, 15 units of glargine, and his next reading was 416 for lunch or pre-lunch. And then he got another 10 units of aspart as reaction to the sugars of 416. Then his next readings were 314. Another 8 units of aspart were given, 3 units of glargine, and then at bedtime he was 103. And so the next morning when his sugars were checked before breakfast, he was 37. And repeat 46, another 53. Then he was given whatever could have been given. Next readings were 320, again reaction, 8 units aspart given, and then the next reading 234. Of note, no adjustment was made to his insulin regimen at this time, and he was continued on the same 15 of Lantus, 15 of glargine, and the medium dose correction scale. For the next 2 days, the same regimen was continued, 15 of glargine with the aspart, and then 2 days after that, again, he woke up with a sugar of 32, 144, 142. At this time, the endocrinology team was consulted. His regimen was changed to glargine 10 units daily and aspart 3 units 3 times a day. And the correction scale was decreased from medium dose to low dose correction scale. And no more hypoglycemia was noted. So a little bit about, islets, insulin, and glucose. So the year was 1869, and a German doctorate student in Berlin called Paul Langerhans Jr., who was also a friend of Rudolf Virchow, was working on the pancreas and examining it under the microscope. And he noticed that there were these cells which were very different from the rest of the pancreas. They were clear. And he initially thought that they were neurons, and he mentioned them in his dissertation, which I shall not butcher as it is in German. And in English, it is Contributions to Microscopic Anatomy of the Pancreas. So in 1893, a French pathologist, Edouard Laguisse, realized that they were involved in digestion, and that's the first time the term islets of Langerhans was used for these cells. Now, the islets are, they're distributed throughout the body of the whole body, head, tail of the pancreas. And they are these balls of cells, which are 1 to 2% of the pancreas, but they get about 15% of the blood flow. And that is very important for the function that they perform. Now, they have a central core of beta cells, which are the insulin producing cells. And here, if you see in the histology in the stains, all of this is the beta cell core. And then it is surrounded by a rim of what are called alpha cells, which are involved in glucagon production. And then we have the neurovascular bundle, which initially goes through the beta cell core, and then it traverses to the periphery, which is the alpha cells and the delta cells, the pancreatic polypeptide cells, and the epsilon cells. So in the year 1921, insulin was discovered by Banting and Best in Toronto, and it was subsequently used to save the life of Leonard Thompson, a type 1 diabetic who did live a few years afterwards, but eventually he did succumb to his illness. And as we know, insulin is a peptide hormone initially generated as a continuous string of amino acids, and eventually this part is removed, which we call C-peptide, and is used in diagnostic purposes. And we have 2 chains, the alpha or A chain, which is 21 amino acids long, and the B chain, which is 30 amino acids long, which are united by these, joined by the disulfide bonds. And how insulin works is by opening the glucose transport channels on the surface of the cell, whereby allowing glucose to enter the cells and removing it from the bloodstream. And if there's one thing to remember, it's that insulin is the main anabolic hormone in the body, and its main role is in, having the glucose taken up by the cells, increasing glycogen synthesis, and increasing lipogenesis, and it decreases lipolysis. And glucose is really important because it's the main fuel of our body, and especially for our brain, one atom, one particle of glucose will give us 30 ATPs. So the body tries to maintain it in a very, very tight balance between 72 to 144. Now, the adult brain uses 20% of the total energy in the body. And even though it is so very reliant on this fuel, it cannot generate glucose at all. So that's why in hypoglycemia, we have something called functional brain failure. And the usual sources are in the fed state. It's from the food that we eat, the carbohydrates, the simple carbs and the complex carbs. And in our fasting state, and within the first 8 hours, we have a process called glycogenolysis, where the stored glucose in the form of glycogen is broken down. And after 8 hours, the liver and the kidneys start making glucose via amino acids and lactate and glycerol, which we call gluconeogenesis. And this is an extremely intricate balance, which is maintained through the interplay of these different organs that are involved. You have the pancreas, liver, muscle, adipose tissue, and day or night, our body is working continuously to keep the glucose in this tight range. So what happens when things go awry? And this is what brings us to our talk on hypoglycemia. So the American Diabetes Association classifies hypoglycemia as a blood sugar reading less than 70 milligrams per deciliter. But signs and symptoms don't occur until the levels drop below 55. So on the basis of that, we can divide or classify it as into 3 levels. Level 1 is when the sugars are between 54 and 70. Level 2 is if it's less than 54. Or level 3 is where the event is so severe that the patient has altered mentation and requires assistance from another person for recovery. And it'll take a few minutes to explain the physiologic responses to hypoglycemia. Now, as I had now mentioned that, the pancreas and the beta cell and alpha cells are closely involved in the control. So we have decreased glucose in the blood. The pancreas detects that. And as I had mentioned, the beta cells are the cells which get the first taste of blood, and it realizes that there's not enough sugar in the blood, so insulin goes down. When insulin goes down, the negative feedback on glucagon is removed, so the alpha cells start secreting glucagon. And the glucagon will go and it'll cause, glycogenolysis and gluconeogenesis, whereby increasing the glucose level in the blood. On the other hand, the brain, since it is starved of its food, starts crying, and it activates the autonomic nervous system, the parasympathetic and sympathetic. And the sympathetic nervous system will also go and tell the adrenals, oh, we're dying, increase your epinephrine. And epinephrine will go and it'll also cause gluconeogenesis and glycogenolysis, whereby increasing the sugar in the blood. And the parasympathetic is what will cause the sweating and the hunger. So now there are different glycemic thresholds of where the different responses come into play. The first thing is the decrease in insulin, which happens when the blood glucose level is 80 to 85. Then the second line of defense is the rise in glucagon when it's between 65 to 70. A third line of defense is our sympathetic system, with this rise in epinephrine. And then there's also cortisol and growth hormone, but they're not as critical. Symptoms tend to occur when the blood glucose level drops below 50 to 55, and that's when the patient is prompted to have food and other symptoms become prominent. And briefly for the symptoms, divide them into neurogenic and neuroglycopenic. Neurogenic is our autonomic nervous system, sweating, hunger, tingling, palpitation, heart pounding, shaking, all that. And neuroglycopenic, as the name implies, is brain and low sugar. So these are what the brain does as a response to the sugars being low, having confusion, brain fog, not being able to think, dizziness, blurred speech, all that. And no talk on hypoglycemia is complete without mentioning Dr. Alan Goldfather Whipple, who came up with the Whipple's triad, where we look at the signs and symptoms of hypoglycemia, the low plasma glucose level, and the resolution of the symptoms once the levels have risen. So what are the main causes? Now, there are a number of different causes of hypoglycemia, but for the purpose of our talk and, inpatient, the important ones are insulin medication, insulin and insulin secretagogues. Alcohol is a big one because patients, especially when they come to the emergency department, if they're intoxicated, they can be hypoglycemic. Because alcohol will inhibit gluconeogenesis, and a lot of times when patients are on binge drinking, they don't really tend to eat food. Critical illness is very important. Hepatic, renal, and cardiac failure all can cause hypoglycemia. Sepsis is extremely important because sepsis can not only cause hyperglycemia, but when it's severe, it will cause hypoglycemia. Malnutrition, anorexia, and undernutrition. And then accidental, surreptitious, or malicious hypoglycemia. And a few words on hypoglycemia-associated autonomic failure. This is important when we are dealing with patients who have had, long-standing diabetes, type 1 diabetics, long-standing type 2, because what it is a beta cell failure. And since the drop in insulin or decline in insulin and rise in glucagon are the first and second line defenses against hypoglycemia, when there is beta cell failure, the patient fails to mount those defense mechanisms. And these are the patients that we can find that their sugars are in the 30s and 40s, and they're still, sitting and they're having a conversation with you, and you're scratching your head as to, what's going on. And patients can also have attenuation of their sympathoadrenal response, which is the third line of defense. Patients with recent hypoglycemic events are more prone to it. So when we have a patient who's had hypoglycemic events, we need to be more wary and more cautious, check their sugars more frequently when they're under our care. Now, glycemic control and the inpatient. Why is it important? It's important because it's a barrier to glycemic control efforts. It's associated with morbidity and mortality, and severe episodes may involve transfer to higher level of care, increased length of hospital stay, increased risk of falls, and of course, healthcare expenditure. And over the recent years, there's been significant attention on identifying causes and minimizing events. So in 2001, Greet Vandenberg et al. Published this study about the intensive insulin therapy in critically ill patients, whereby they showed that patients whose sugars was kept below 110, they actually had better survival in the ICU compared with the conventional treatment. Now, the conventional treatment was with their glucose being 180 and above. So there's a wide range between 180 and 110. However, on the basis of this, there was, a push towards much stricter control of blood glucose in the hospital setting. But then in 2008, the VICEP trial was done, which was more a pentastarch resuscitation trial in severe sepsis. However, one thing they did note that the patients who were placed on insulin therapy versus fluid resuscitation, they noticed that the patients who had sugars in the 80 to 110, they had more hypoglycemic events. And with the severe hypoglycemic events in the ICU, there was a higher chance of prolonged stay in the ICU. But interestingly, they didn't notice a change in mortality between the two groups. However, a study that we're familiar with, the NICE study published in 2009, which was done on 6,000 ICU patients, they divided them into two groups, the intensive glucose control with sugars between 81 and 108, and the conventional glucose, which is sugars less than 180. And they did notice that there was an increased mortality by 2.6% in the patients in the intensive control group. And they also had severe hypoglycemia with sugars being less than 40, which was more common in this group. So they suggested that there was a link between hypoglycemia and mortality. So what is the incidence? It's hard to say. One study said 7 to 10% of patients will have at least one episode of hypoglycemia, but the true incidence is hard to assess. Now, it can range from 0.5 to 32.8. And the reason it's so hard is because there's no standardized definition that is used in studies. Some studies will take 70 as their cutoff. Some will take 40 as their cutoff. We used 45 as our cutoff. This study, like NICE sugar, VICEP, and Glu Control used 40. And another thing was different methods of data collection. Some will use point of care, some use plasma glucose, and now actually CGMs are being used as well. So there's no standardized cutoff used in these studies. And then there are patients who have hypoglycemic unawareness, because in the hospital, unless they're just doing the routine check, sugars aren't checked 24/7. So they can be patients with hypoglycemia unawareness who go missed. And there can be inadequate frequency of glucose checks. And now with CGMs, they're showing that the events are underreported by self-monitoring and are often clinically silent. However, regardless, So with the NICE study, after it had come out, then they started looking at events of hypoglycemia in the hospital. So in the Journal of Hospital Medicine, they did a survey in 126 US hospitals, and they noted that 10% of patients in the ICU and 3.5% of patients in the general ward did have at least one episode of their sugars being less than 70. And in Brigham and Women, in New York, they looked at 31,970 patients with and without diabetes admitted to the general ward, and they showed that at least 10.5% had at least one reading of blood glucose less than 70 during their hospital stay. So that's one in 10 patients. So the different types of inpatient events can be broadly classified into primary, when it's the primary cause of the admission, secondary, when it occurs during the hospital stay, iatrogenic, when it's because of overly aggressive treatment of hyperglycemia, or I should have added, hyperkalemia, essentially when you're treating and the treatment causes the sugars to go low, the glucose to go low. Spontaneous, for example, in patients with multiple organ failure, malnutrition, history of drug consumption, which can predispose to hypoglycemia. And then spurious, which are false or pseudo. There are different risk factors that we should be aware of. We have patient factors, nutrition factors, and systemic and management factors. And in the patient factors, the most important ones that I want everyone to be aware of are, renal insufficiency and especially acute kidney injury, and sepsis, continuing long-acting sulfonylureas in the hospital, the duration and type of diabetes, because type 1 more prone to hypoglycemia, long-standing type 2 more prone to hypoglycemia unawareness, low BMI and malnutrition, organ failure, insulin treatment at baseline, because that would imply that these patients have had diabetes long-standing, advanced stage, chronic kidney disease, and malignancy. And just a few words on hypoglycemia and chronic kidney disease, since it's just so very important. It's an independent and important risk factor because the kidneys are involved in gluconeogenesis, and when there's kidney disease, we have reduced gluconeogenesis. There's increased insulin half-life, and there's a decline in the hepatic insulin metabolism due to uremic toxin effects on the liver. And this for us exceedingly important to know that if we take one as a reference, and this was published in 2009, if you take one as a reference, so CKD without diabetes, less chances of hypoglycemia versus a diabetic without CKD. But if there is a person with diabetes and chronic kidney disease, they have the highest risk of going hypoglycemic in the hospital. So these are the patients we should have the strictest blood glucose checks for, and low index of suspicion. Nutrition, very important risk factor, lack of coordination between the meal delivery, blood glucose monitoring, and prandial insulin administration. Huge issue, but very challenging to manage. Reduced oral intake while inpatient. Patients don't feel as well, they don't want to eat as much, but their regimen may not be altered. The food quality is different in the hospital. I mean, of course, patients will tend to eat differently at home. Not everybody, but most of them. And there's much more easy access to snacking at home than there is in the hospital. Failure to address changes in nutrition status. Patients made NPO, and their meds weren't held or weren't reduced. And failure to address changes in regimen for tube feed and TPN. And one very important thing to note here is, if they lose access, they should be started on, D5 or D10, and their regimen must be addressed at that time because that's a hypoglycemic event waiting to happen. And systemic and management factors. A lack of communication between the different teams involved in the patient's care. Extremely important. It needs to be worked on and improved. Failure to address changes in steroids. Huge. Patients getting IV solomedrol, changed to oral. Patient getting IV solomedrol 3 times a day, changed to twice a day. The insulin they're getting has to be changed, has to be modified, and it has to be communicated. Failure to adjust home medication, prolonged use of sliding scale as monotherapy, failure to make changes to glycemic therapy on the basis of the daily glucose pattern. For example, our patient that we discussed earlier, if changes had been made after the initial hypoglycemic event, the second may have been prevented. Lack of ownership, too many cooks in the kitchen, sometimes things can go awry. Now, what's the impact of hypoglycemia? We have non-medical impact and medical impact. Non-medical, increased length of stay. Studies done 2012, they showed that the length of stay was 2.3 days higher in patients with a severe event and 1.5 days higher in patients with a mild to moderate event. And length of stay equals money. And another study showed that patients with at least one episode of hypoglycemia, which they defined as 50 milligrams per deciliter, the length of stay was 2.8 days longer. Cost. Each event has significant cost on the healthcare resource utilization. And this is a very interesting paper, was published 2021. And they looked over, they did a PubMed search and they looked at a number of different studies published all through over the world. Then they translated all of that into US dollars and say, for each hypoglycemic event, ambulance cost can be $664 per event. The emergency department can be $3,000 per event. And hospitalization for patients with severe hypoglycemia. Type 1 diabetics can, 1.7 days can be added to their stay, which equates to thousands of dollars. Similarly, for type 2, apparently type 2s can end up staying longer in the hospital than type 1. Type 2 on basal insulin can be even higher, 5,000. So a lot of numbers here, but essentially it's just a representation that of the fact that each hypoglycemic event equates to thousands of dollars. And then it also increases the readmission rate. Patients who had a hypoglycemic event close to their discharge, the chances of being readmitted is higher as compared to if they had not gotten hypoglycemic. And a hospital system in Florida showed that the readmission rate was 21.8% for patients with severe hypoglycemia versus 13.5% for normal glycemia. And the average cost per stay was 94% higher per admission. Now, a lot of different numbers. Each study comes up with a different percentage and a different dollar amount. However, the crux of it is it all equates to increased length of stay, increased readmission rate, and increased healthcare cost. The medical impact of hypoglycemia is cardiac complications, increased morbidity and mortality. And for cardiac complications, the lower the plasma glucose and the longer the time in hypoglycemia, the higher the risk. Can start off with simply QT prolongation, then we can have ventricular contractions, then a VTAC, we have AV blocks, third degree block, finally cardiac arrest. And this is due to the activation of the sympathetic parasympathetic nervous system. And interestingly, when the patient is awake, they're going to be more cognizant of their symptoms. The chances of having VTAC is higher. But you can see that when they're sleeping, they can go unnoticed for long. And these are the patients that will present in blocks. And anyone who's worked in the hospital knows that at 2 a.m. you may be called because the patient's bradycardic and they're in heart block. And it's like, okay, now what do we do? So check their sugars. And of course, mortality among hospitalized patients with hypoglycemia, insulin-related and non-insulin related. The most important thing is whether it's insulin-related or whether it's non-insulin related, hypoglycemia is associated with a mortality risk of 31.9%. Now, CMS has become aware of this and they've come out with these glycemic measures. The annual update for the fiscal year 2022, released in August 2021, included for the first time hospital harm glycemic measures. Now, there are 11 CQMs for both hypo and hyperglycemia. This is just a hypothetical timeline. And according to this, there are possible financial penalties 2025 and onwards. Just briefly, for those who may be interested, the CMS hospital harm eCQMs for severe hypoglycemia. The description is proportion of inpatient hospitalizations for patients who are administered at least one hypoglycemic medication during the encounter in which the patient suffers the harm of a severe event. Intention to measure iatrogenic events triggered by the incorrect use of insulin or another hypoglycemic medication, as severe hypoglycemia is considered a largely preventable adverse event. The numerator, number of inpatient hospitalizations that include a severe event during the encounter, which they define as the blood glucose being less than 40, and a hypoglycemic medication administered within 24 hours before the start of the severe hypoglycemic event and during the encounter. Only the first qualifying severe event is counted in the numerator, and only one severe event is counted per encounter. The denominator is the number of inpatient hospitalizations during which the patient received at least one medication during the encounter. This includes administration of medication in the emergency department or when the patient is in the observation status at the start of the hospitalization. And exceptions are patients who are less than 18, so not for pediatrics, or patients who have a blood glucose value less than 40 with a subsequent retest value greater than 80 within 5 minutes, because that we consider the spurious reading. And just for hospital medicine folks out there, the Society of Hospital Medicine has come out with this eQuips program, glycemic control eQuips, online approach to glycemic control program. And there's a YouTube link here for those who may be interested. Few recommendation strategies, relatively relaxed glycemic goals, pre-meal less than 140, random less than 180. Treatment regimen. Both ADA, ACE, and Endocrine Society recommend using basal insulin once or twice daily and prandial, rapid-acting insulin, before meals when patients are stable and eating. Oral agents should be discontinued, especially sulfonylureas. Blood glucose monitoring. If they're on a diet, ACHS, 2 a.m. checks in select patients. If they're NPO, every 4 to 6 hours. And if they're on an insulin infusion, every 1 to 2 hours. Restrict use of premixed insulin and concentrated insulin, and weight-based dosing. Another important thing, hyperkalemia. Rather than giving 10 units stat for everybody, there was a study done in which they suggested using 0.1 units per kilogram with a maximum dose of 10 units, and they actually showed that there was a reduction in hypoglycemic events by 50%, whereas the potassium lowering was similar in both groups. And I have the reference here in case anyone would like to refer to it later on. And then transition from IV to subcutaneous insulin in the ICU. Look at how much insulin the patient required in the past 24 hours, give 80% of the total daily dose, half as basal, half as prandial, but do take into account how much the patient is eating, because if they're not going to be eating as much, they're feeling sick, nauseous, they're going to be NPO for procedures, give them less prandial, more basal at that time. Patients with stable intake, you can do 50-50. Just a few words on CGM. This was a recently published, and CGMs were used to evaluate hypoglycemia in the general ward. They randomized clinical trial, and they looked at patients with type 2. Primary outcome was difference in inpatient hypoglycemia, and a total of 72 participants were included. And there were 60.4% fewer hypoglycemic events in the patients with the CGM, and most likely because you could see when their sugars were dropping, and remedial actions could be taken in due time rather than the sugars dropping below 70 and then the patients being noticed. So coming to our inpatient hypoglycemia task force at the VA, includes Dr. Satya Krishnasamy, Dr. Priya Krishnan, Dr. Sudhir Narayan, Kimberly Riebling, our patient safety manager, and the endocrinology fellows. So it all started in 2010 when it was noticed that there were patients who were having quite, they were hyperglycemic, they would get insulin, and then after an hour, someone would check it again, give more insulin, and then they would be stacking, and then the patient would crash, kind of similar to what happened to our patient. And then changes were made, including making the HS scale to start at 201 milligram per deciliter rather than at 150. In CPRS, they made changes so that the low dose correction scale, it says, should be given for patients whose total daily dose is less than 40. Medium dose if their daily dose is less than 80, 40 to 80, stopping the medication on admission, oral meds. And then things did improve for a little bit, but then in 2021, they noticed that the events were increasing again. So this committee was formed, and what we do is we look at monthly reports and we track the frequency of the inpatient events. We look at patients who had blood sugar readings, blood glucose readings less than 45. And then we study each and every individual event. We meet every month, go over each event, look at their comorbidities, how much insulin was given, the description of the event, and then we do come with a root cause analysis to identify the common causes and risk factors, and then we work towards implementing changes. So this is the data collection form that we use. It has the age at onset of diabetes, the A1C, the pertinent medications that they're taking, the comorbidities, home glycemic regimen, inpatient regimen, nutritional status, the event description, admitting service. And then, as I mentioned, we look over all the different patients with their events less than 45. We look at the venous and point of care glucose, go over it in CPRS, and then we convene every month. So part of this was done by my colleague last year, who reviewed the events between October 2021 to March 2022. And I was involved in the data analysis from September 2022 to February 2023. So in the first 6 months, or the initial 6 months, 23 cases were identified. 3 cases were excluded for having pseudo hypoglycemia, and then 20 were left in the end. For us, it was 20 cases were identified, 5 cases were excluded, but a total of 15 cases were reviewed and analyzed. Initially, it was noted that most of the patients, at 85%, were 65 years and older, with a average age of 72. For us, 50% were 65 and older, with the average age of 63. 60% had type 2 diabetes, 10% had type 1 or LADA, 5% were type 3C, and 25% were not diabetic. 9 out of the 20 had chronic kidney disease. 6 of them had acute kidney injury on top of the chronic kidney disease. 3 had malignancy, and 5 were septic. Now, few of the causes that we found: failure to address insulin after changes in steroid dose. This was seen in the initial 6 months, not in our 6 months, which is an improvement. Using the inappropriate correction scale, seen in the initial 6 months in 4 patients, we saw 1. Failure to schedule prandial insulin coverage, 1. Using non-standard premix insulin, 2. But after that, we removed premix insulin from the formulary. Spontaneous hypoglycemia due to critical illness. In our case, we had 2 patients. 1 patient was terminal and he died the next day. The other patient had low BMI and poor oral intake in the hospital. Stacking of insulin. Iatrogenic hypoglycemia due to sulfonylureas, 2 in the initial 6 months, none in ours since we removed sulfonylureas. Hypoglycemia after hyperkalemia treatment. This surprisingly went up, and this is where some work can be done. Insulin drip protocol mismanagement, none seen in our 6 months. Failure to address diabetic medication before or after surgical procedure with low blood glucose on presentation. 2 patients who presented, 1 came for a cardiac cath and 1 came for another procedure. They were actually hypoglycemic on presentation. So they likely either took their Lantus at night or their sulfonylurea before presenting, which contributed to their low glucose on admission. Delay in starting IV fluids. We had 3 patients. 1 was NPO, 1 had taken Lantus, and 1 took sulfonylurea at home, had AKI with poor oral intake. Lantus duplication was seen in 2 patients. By duplication, I mean the patient came, Lantus was ordered as a Q day, but they also got a dose at night. So they got it at night, and then they also got another dose the next morning, and there was duplication, which likely contributed to the event. And then pump therapy or lack of communication. There was one patient who was on an insulin pump. He had been made NPO, but the team managing was not informed, and the patient was not put on basal, temporary pump settings. So that contributed to the event. So changes implemented by the committee, which have already taken place, limiting the use of U500 to endocrine, modified bedtime correction scale starting at 201 rather than 151, discontinuing the home oral diabetes medication on admission, no premix insulin while inpatient, endocrine referral for all insulin pump patients, and enhanced utilization of inpatient diabetes education resources. Further recommendations: limit excessive reliance on the sliding O correction scale, use appropriate correction scale according to the total daily dose. The low dose if the total daily dose is less than 40, medium if it's 40 to 80, high only if the patient's requiring more than 80 units of insulin per day. Reiterate the importance of prandial coverage. Any patient that is eating should not be on a correction scale alone. Encourage effective communication between the different teams involved in the care. I think linking the steroid use with an alert to inform the endocrine team or whoever's managing the glycemia should be made. Inform endocrine team or the team managing the glycemic regimen when there's a change in the nutrition status. Avoid insulin stacking, which means not checking sugars every hour and giving more and more insulin, or waiting a little while for it to actually act. Creation of insulin pump, standard operational protocol, and weight and renal-based dosage of insulin in the management of hyperkalemia. And this is just a graphical representation of, ever since we started somewhere, 2020, 2021, there was quite a, uptick in the events of hypoglycemia. But towards the end, there has been a significant improvement and decline. So I think we're doing good work. So our patient, failure to use prandial and scheduled aspart for a patient who's eating by mouth and receiving bolus insulin, the bolus tube feeds, using a moderate dose correction scale for a patient with a total daily dose of insulin less than 40. And I'd like to thank Dr. Satya Krishnasamy, Dr. Priya Krishnan, sorry, there's an E missing here, Dr. Sudhir Narayan, Kimberly Riebling, and Dr. Zachariah Sabai for all your help and for involving me in this really great work that we've done. Today's event code is 1282703. I believe that is what it is. So thank you, everyone. Thank you.
Newer injectable diabetes agents like the GLP-1s and the combination, what are your thoughts about continuing those in the inpatient setting versus the sulfonylureas, we typically do metformin if we're worried about contrast and kidney and SGLT2 versus glycemic CKD. What about things like Ozempic or Mounjaro?
I would lean towards holding them while they're inpatient because like patients who are admitted, they can be sick, they can be nauseous, and these medications do work by reducing oral intake. So we're already dealing with someone who is feeling unwell or sick, and their oral intake may be affected. So I would lean towards holding them while they're admitted.
Yeah, I think they can be used in nursing homes or rehab.
Yeah, but those are stable patients.
Because they're going to be there for a longer time. When they come in, and you don't know when they got their last shot.
Yes.
It's a weekly injection. So hopefully many of these people are not.
Getting them in the hospital. At
Right.
least in our like UofL, I think we have on.
And they would be made NPO.
The other thing I've noticed is
Have you looked at, so nowadays, of course, there are people who are wearing their CGMs. Yeah, and they're admitted and will continue to wear it. You can look at, was there any difference in the hypoglycemia rates and those who were wearing CGMs versus those who were not?
So they did mention a study recently where they noted that the patients who were wearing the CGM had early detection of their events. So in other words, the ones who were not wearing the CGM had more hypoglycemic events versus the ones that were wearing it. So the ones that were wearing it most likely prevented them from going hypoglycemic. So there is work that's being done on this, and they've already had a publication on it. So I would lean towards allowing patients to wear their CGM.
With the knowledge that you can't hear them.
Can't hear anyone.
Type the question.
There are questions in the chat.
Here's the chat. Okay. Okay. Dr. Winters asks, have any regulations or learning changed between 2022 and 2023?
Obviously, there was some impact.
In the VA, at least, we didn't have any event in March, so certainly there has been improvement since we started this initiative. Not sure about regulations or learning changes between 2022 and 23, but certainly the number of events has gone down. Thank you, everyone. I'm seeing
I had a
that.
question about.
So Dr. Kotwal asks, how about the incidence of hypoglycemia and type 2 diabetes due to higher doses of glipizide or Ozempic or other anti-diabetic medications? So in the hospital, we lean towards stopping oral agents and just having patients on basal bolus. And GLP-1s at this point in time are not continued in the hospital. Don't see any other questions.
Thank you.
Right. Thank you, everyone.
That was
Yes.
Specific. Or that was more.
Well, in the VA, most of them are on the, I think, 6th floor and 5th floor anyway. So
6, 4, and 5.
yeah.
Actually, we didn't go those specific for our study.
Yeah.
But the hospitalist, Priya being the chief hospitalist and the chief of medicine there, was able to, I think they were able to recognize internally and keep the education within us. But for the study, we didn't use that kind of thing. Yeah, certainly there was some specific.
Right. Thank you. Thank